بسم الله الرحمن الرحيم. نبدأ السيشن بتاعتنا عن البريست كانسر. بشكر الدعوة الكريمة من الأخت الفاضلة الدكتورة ريما عماد، وتمنياتي بالتوفيق دايما يا رب. وبتشرف بالكوتشير معايا دكتور مدحت، أهلا وسهلا. هنبتدي الفيرست سبيكر معانا الدكتورة رحاب محمد عباس، هتكلمنا عن كونتراست انهانسد ماموجرافي ان بريست ليجن. دكتورة رحاب اتفضلي.
بسم الله الرحمن الرحيم. هنتكلم النهارده عن contrast enhanced mammography. دكتور رحاب محمد عباس، Head of Mammography Unit at Kenya Oncology Center. Breast cancer is one of the most common malignancies in female population in Egypt. So دلوقتي احنا في المبادرة بنستخدم فيه tools كتير احنا بنستخدمها، منها الماموجرافي which is the cornerstone in breast imaging. الماموجرافي ده is the best important tool in diagnosis of breast cancer which is used in dense breasts. 4 of 10 cases could be missed by screening mammography. So we use supplementary tools used to more assist. We use ultrasound and contrast enhanced studies which is MRI or contrast enhanced mammography. The disadvantages of الماموجرافي انه بيبقى ليه low sensitivity و low specificity. Since اللو sensitivity بتاعته ان ممكن يكون في عندنا normal breast tissue obscure abnormalities وراه، فبالتالي بيدينا false negative result. اللو specificity ان هو بيبقى superimposed breast tissues، بيبقى normal glandular tissue بيبقى superimposed على بعض، فبيدينا false abnormality اللي بتدي false positive result. So we use the contrast enhanced mammography which is the modality that combines digital mammography 2D images بتاعت الماموجرافي العادية جدا، بس بندي معاها IV contrast material. ال contrast enhanced mammography used to detect cancers that are occult on standard non-enhanced mammography, and it is a technique which is to explore angiogenesis by tracking الuptake والwash out بتاعت contrast agents through lesion. The main advantages of the contrast enhanced mammography which is the immediate availability بالمقارنة بالhigh cost والlimited availability of MRI, no special training of the technologist, and is complete assessment without any remaining questionable finding without new appointment. Faster imaging and direct correlation with the mammography studies, and it is used in extremely high spatial resolution. بدينا ان اللو انرجي ايمجز بتاعت الكونتراست انهانسد ماموجرافي دي بنستخدمها في ان احنا بنشوف بيها المايكرو كلاسيفيكيشن. الفكره بتاعت الكونتراست انهانسد ماموجرافي ده ان انا بستخدم اللي هي الستاندرد ماموجرافي ايكويبمنت العاديه جدا، الجهاز بتاع الماموجرافي، بس بيبقى فيه معاه upgraded ان هو بيبقى فيه كبر فلتريشن واديشنال سوفت وير that makes the unit capable of performing dual energy imaging. ودي الفكره بتاعت الكونتراست انهانسد، ان احنا يكون في عندنا dual energy. الايمجنج اللي احنا يعني احنا في الاول بندي الكونتراست اللي هي بتكون هاي انرجي، بعدها بناخد السي سي بتاع النورمال بريست، بعدين بناخد الام ال او بتاع الافكتد بريست، وبعدين الام ال او بتاع النورمال بريست. زي ما قلنا الفحص تقريبا بياخد من 5 6 دقائق. الكونتراست انهانسد ماموجرافي الليكسيكان بتاعه بيعتمد على المورفولوجي بتاع الانهانسنج ليجن، زي ما قلنا بيبقى على حسب الشكل نفسه الانهانسنج، يعني على شكل الانهانسنج انا هقدر احدد يعني سواء كان الليجن ده بناين ولا مالجنانت. الليكسيكان بتاعه هو عباره عن كومبينيشن ما بين الماموجرافي والام ار اي. التايبس اوف كونتراست انهانسد ماموجرافي انهانسمنت في عندنا نوعين. الاول حاجه بيبقى فيه اللي هو الباك جراوند بارينكيمال انهانسمنت اللي هو نورمال الانهانسمنت بتاع النورمال بارينكيما. تاني نوع عندنا اللي هو الابنورمال انهانسمنت، ده اللي هو بتاع الليجن اللي انا بقدر احدد منه سواء كان بيناين ولا مالجنان. لو جينا بصينا هنا هنلاقي ده النورمال باك جراوند بارينكيمال انهانسمنت. في منه عندنا تايبس، في مينيمال انهانسمنت، في مايلد انهانسمنت، ومودريت انهانسمنت، وماركت انهانسمنت. المورفولوجي بتاعها بعد كده بنبص على زي ما قلنا على الانهانسنج ليجن نفسها. التايبس بتاعتها انه بيبقى ممكن تكون فوكال انهانسمنت، وممكن تكون ماس، والماس دي بيبقى بنكومنت على المارجن، الشيب، الباترن اوف انهانسمنت بتاعها، او يكون في عندنا نون ماس انهانسمنت، ودي بتبقى شكلها فوكال ولينير وسيجمنتال وريجنال ومالتيبل ريجنز وديفيوز انهانسمنت. هناخد الفوكس انهانسمنت. الفوكال انهانسمنت ده بيبقى دوت اوف انهانسمنت، بتبقى راوندد سموث without mass effect within 5 to 10 ملم، ودي غالبا بتبقى دي بتكون غالبا اللي هي الكرايتيريا بتاعت البناين ليجن. لكن برضو ممكن تكون الفوكس انهانسمنت دي ممكن تكون مالجنانت. لو جينا بصينا على البناين ومالجنانت ليجنز اللي ممكن تبقى عامله فوكال انهانسمنت على الكونتراست انهانسد، ماموجرافي البناين ليجنز ممكن تكون عندنا بابيلوما وسمول فايبر ادينوما او انترا مامري ليمف نود which is common finding مع الكونتراست انهانسد ماموجرافي، ودي بنعرفها بالكومن سايد بتاعها ان هي بتكون موجوده في الابر اوتر كوادرنت. المالجنانت ليجنز بتبقى واخده فوكال انهانسمنت ان هي ممكن تكون فوكال دي سي اي اس او فيري سمول ليجن اوف داكتا كارسينوما انسايت. لو جينا بصينا هنا على الصوره دي هنلاقي في ال2 دي ايمجز العاديه هنلاقي ان في عندنا في upper outer quadrant lesion موجود، ولو بصينا على السنتر بتاعه هنلاقي فيه central lucency. هنلاقي فيه central lucency هنا جوه الليجن نفسه، وده موجود upper outer quadrant وعامله focal enhancement well defined جدا، ودي بتبقى دي intramammary lymph node. لكن لو جينا بصينا على الصوره دي في 2 دي ايمجز بتاعت الماموجرافي العاديه في عندنا سمول ليجن، لكن لو بصينا على المارجنز نفسها بتاعته هنلاقي ان هي سبيكيوليتد مارجن. بس هو هنا بيعلق الليجن نفسه، لو جينا بصينا عليه هنلاقي ان المارجنز نفسها بتاعته فيها سبيكيوليشن شويه. لما جت عملت الكونتراست انهانسد ماموجرافي هنلاقي ان في فوكال انهانسنج ليجن، والمارجنز بتاعتها برضو زي ما قلنا ان هي شكلها مش سموث، ودي لما اخدت بايوبسي طلعت اي دي سي. تاني حاجه عندنا اللي هو الماس انهانسمنت، وده زي ما قلنا ان احنا بنكومنت على بنشوف الشيب نفسه بتاعها سواء كانت راوندد ولا اوفال ولا irregular، والمارجنز بتاعتها circumscribed non circumscribed irregular speculated. بنبص كمان على الماس نفسها بنشوف الانهانسمنت بتاعتها سواء كانت هوموجينوس ولا هيتروجينوس ولا عامله ريم انهانسمنت ولا دارك انترنال سبتيشن. الهوموجينوس انهانسمنت لو جينا بصينا هنا على الليجن ده هنلاقي في عندنا ليجن dense lesion more or less well defined margins بتاعته. هو بيعلق طيب اوكي، لا هو نفسه اصلا. طيب لو جينا بصينا على الليجن ده هنلاقي في عندنا ليجن موجود well defined و more or less smooth outline، لكن في والكونتراست انهانسد بتاعته بتبقى homogeneous ان الليجن كله واخد enhancement. الباترن التاني بتاعنا اللي موجود ان يكون في عندنا heterogeneous enhancement، ان هنلاقي فيه ليجن بيبقى في جزء منه واخد كونتراست وفي جزء تاني لا مش واخد، ده اللي هو اللي بيبقى دارك في النص ده غالبا بيبقى البريك داون بتاع الليجن، وده برضو من ضمن المالجنانت ليجنز الانهانسمنت بتاع المالجنانت ليجن. تالت باترن معانا ان يكون في عندنا ريم انهانسمنت، ان يكون الليجن نفسه من بره هو اللي واخد انهانسمنت لكن السنتر بتاعه لا. رابع نوع معانا هو الدارك انترنال سبتيشن، ان يكون في اجزاء من الليجن واخده انهانسمنت لكن لو جينا بصينا هنلاقي في النص فيها سبتيشن والسبتيشن دي مش واخده انهانسمنت. النوع اللي معانا بعد كده اللي هو النمس انهانسمنت، ان يكون فيها ده بيبقى ليه كذا شكل منه اللي هو الفوكال دي عباره عن اريا اوف انهانسمنت اقل من الكوادرنت اقل من البريست كوادرنت، ده برضو بيبقى موجود مع المالجنانت ليجن. تاني تايب معانا اللي هو اللينير انهانسمنت، وده بيبقى موجود مع موست كومنلي مع الدكتال ليجنز. النوع الثالث بعد كده السيجمنتال انهانسمنت، وده بيبقى شكله تريانجولار شيب والايبكس بتاعته ناحيه النبل، وده برضو بيبقى كومن مع الدكتال ليجنز زي الدكتا كارسينوما انسايت. رابع نوع معانا اللي هو ريجنال انهانسمنت، والريجنال انهانسمنت ده بيبقى واخد كذا مكان كذا كوادرانت في البريست بيبقى انكلودد بيبقى كلهم كونتينوس مع بعض، ده الريجنال انهانسمنت. النوع الخامس بعد كده ان يكون في عندنا مالتيبل ريجنز، ان هو بيبقى فيه كذا باترن من انهانسمنت زي هنا في عندنا فوكال انهانسمنت وتحت في عندنا ده سيجمنتال انهانسمنت وما في ما بينهم نورمال بريست تيشو. الانواع اللي احنا اتكلمنا عنها الفوكال واللينير والسيجمنتال والريجيونال والمالتيبل ريجنز دول غالبا بيبقوا مع المالجنانت ليجن. لو جينا بصينا هنا هنلاقي ان في عندنا في فوكال انهانسد زي ما اتكلمنا ان هو جزء صغير موجود. بعدين تاني نوع اللي هو linear enhancement هنلاقي في عندنا linear enhancement هنا موجود على contrast mammography. بعدين segmental دي اللي هي واخدة الكوادرانت من البريست. بعدين الريجنال ده اللي واخد كذا مكان من البريست كذا منطقة كذا كوادرانت included منهم retroaerial region. بعدين multiple regions ده بيبقى كذا منطقة وفي ما بينهم normal breast tissue. بعدين الديفيوز انهانسمنت ده بيبقى واخد بيبقى هو ده زي اللي هو بارينكيم انهانسمنت اللي احنا اتكلمنا عليه في الاول. بعدين بيبقى فيه نو انهانسمنت في ليجنز بتبقى ما فيش فيها اي انهانسمنت. هنا لو جينا بصينا على البيشنت دي 45 years old female patient with right breast mass with indistinct border. لو جينا بصينا على المارجنز نفسها هنا بتاعت الليجن من تحت عند النبل سوري بوينتر بس عشان مش شغال قوي بس في جزء هنا ناحيه النبل ده البوردرز بتاعته indistinct. لما جينا عملنا contrast enhanced mammography ان الليجن ده مش واخد اي enhancement خالص which is common مع البناين ليجنز دي زي الفايبر ادينوم. لو جينا بصينا برضو هنا على الليجنز ده هنبص على 2D image العادية هنلاقي ان في عندنا في well defined lesion موجود وليه smooth outline ليه smooth outline. هو في مشكلة في ان هو اصلا مش متظبط مش جاي اللي هو السهم اوريدي متشاور عليه ان في عندنا well defined lesion وليه smooth outline. لما جينا عملنا contrast enhanced mammography لقينا ان الليجن ده مش واخد اي enhancement خالص which is common مع البناين ليجن دي زي الفايبر ادينوم. لو جينا بصينا على السونار ده هنلاقي ان في عندنا في well defined lesion ايزوكويك مدينا شكل breast and breast lesion which is the hamartoma. ده لما بنيجي نديله contrast enhanced بنعمله على contrast enhanced mammography برضو مش بيبقى واخد اي uptake خالص من الكونتراست اللي هو موجود في الجزء الابر ده. لا مش مظبوط برضو انا عايزه اشاور مثلا على جزء هنا بس هو بيبقى بيروح في جزء تاني. ما انا عارفه بس هو برضو مش متظبط يعني ممكن حضرتك تجيبه هنا. اوكي يا ريت. لما جينا اخد الكونتراست انهانسد ماموجرافي هنلاقي ان هو هنا الليجن مش واخد اي ابتيك فده بيبقى كومن مع الهامرتوما. لو جينا بصينا في البيشنت دي بيشنت عندها ليفت بريست كانسر وعملت ليفت بريست كونزرفتيف سيرجري. لو جينا بصينا في 2 دي ايمجز هنلاقي ان في عندنا في اريا اوبرينكيمال ديستورشن مكان الاوبرتيف بيد موجوده اللي هو السهم متشاور عليها. في العادي هندخل في ديبيت جامد جدا ان البيشنت ده بيبقى فيه ريكارنت ولا لا ده من كتر ما بيبقى فيه ديستورشن مكان الاوبرتيف بيد. ففي بيشنت بنضطر ان احنا ناخد منها بايوبسي عشان تشور اذا كان في ريكارنس ولا لا. الكونتراست انهانس ماموجرافي بيخدمنا جدا في النقطه دي ان هو الليجن في الديستورشن لو ما كانش فيها اي انهانسمنت خالص معنى كده انه نو ريكارنس نو انهانسمنت دي نو ريكارنس. لو جينا بصينا في الايمج دي في الماموجرافي ايمج هنلاقي ان في عندنا ويل ديفايند ليجن اوف ميديوم دنسيتي ليه سموث اوتلاين. في كونتراست انهانسد لما جينا عملنا سونار للبيشنت دي طلع ان في عندنا well defined cystic lesion وليه posterior enhancement. لما عملت الكونتراست ماموجرافي ادانا اللي هو signs of dark ball sign which is the simple breast cyst. لو جينا بصينا في الايمج دي هنلاقي ان في عندنا في 2 دي images هنلاقي ان في right retroaerial area of architecture distortion وفي معاها second scan موجوده بس احنا ما فيش اي definite mass lesion ان احنا قادرين نشوفها بال 2 دي images. لما عملت الكونتراست enhanced mammography لقينا ان في عندنا heterogeneous area of heterogeneous enhancement في mass lesion موجودة فيها heterogeneous enhancement. لو جينا بصينا ناحية ما بين الماس ليجن دي وما بين النبل هنلاقي إن في كمان small lesions تانيين موجودين. فده كانت multifocal breast lesion which is not present في 2D images العادية. في البيشنت دي هنلاقي إن في upper outer left upper outer area of architectural distortion with no definite برضه mass lesion. احنا مش قادرين إن احنا نحددها بال 2D images العادية. بعد contrast enhanced mammography هنلاقي إن في عندنا في homogeneous mass enhancement، وده اللي احنا شايفينه اللي هو الفوكال enhancement ده، ودي لما أخدت بايوبسي طلعت IDC. في البيشنت دي هنلاقي ان في عندنا في clusters of polymorphic microcalcification، برضو ما فيش في عندنا اي definite mass lesion could be seen ب 2D images العاديه. بعد contrast enhanced mammography لا لقينا ان في عندنا في multiple mass lesions موجودين، ودي لما سحبت بايوبسي طلعت IDC with DCIS component. الفايندنج اللي اداها لنا كونتراست انهانس ماموجرافي سيميلر جدا للداتا اللي اداها لنا الام ار اي. برضو ان هو في الام ار اي ادانا ان في مالتي سنتريك بريست ماس ليجنز دي، لكن المايكرو كلاسيفيكيشن مش بتبقى ديتكتابل قوي في الام ار اي بالمقارنه بال 2 دي ايمجز والكونتراست انهانس ماموجرافي العاديه. بس في الاخر طبعا مع المقارنه باننا عندنا الكونتراست انهانس ده الافيلابيلتي بتاعته والكوست بتاعته طبعا اقل بكتير جدا من الام ار اي. لو جينا بصينا في الايمج دي هنلاقي ان في عندنا multiple rim enhancing breast cavities lesions، ودي بتبقى common جدا مع الكرونيك non specific granulomatous mastitis، ودي برضو نفس الداتا اللي اداها لنا الام ار اي ان في عندنا multiple lesions موجودين ليهم peripheral rim enhancement. Finally, contrast enhanced mammography ده used in cases of dense breasts in high risk female, diagnosis equivocal lesions on digital mammography, detection of الاوكالت lesions اللي احنا مش بنقدر نشوفها بال 2 دي الايمجز اللي هي الصور بتاعت الماموجرافي العاديه، precise determination of the extent of the disease, tumor size and number. زي ما شفنا ان احنا بيبقى بحدد منه الليجنز، ممكن يكون في عندي على 2 دي ايمجز ظاهر ان في ليجن واحد، لكن مع الكونتراست انهانسد لا ممكن يطلع ان في multiple lesions موجودين. assessment of operative bed local recurrence زي ما قلنا انه no enhancement no recurrence. monitoring response to chemotherapy. Thank you.
شكرا يا دكتورة رحاب على
عفواً.
المحاضرة الجميلة. احنا ممكن ناخد سؤالين سريعا كده من الفلور. دكتور محمد.
Dr. Rahab, thank you for the presentation, and my question is monitoring the response to chemotherapy. So, any valid scoring system for grading the response? I mean, it's just subjective assessment of the response. I mean, we are now recruiting more cases for neoadjuvant chemotherapy and
Right.
targeted therapy. So, do you have any validated scoring system so I can rely on?
احنا الفكره كلها ان احنا في بيشنت لما تيجي تاخد الكيموثيرابي في الاول ولما بتبقى ميزد الكليبنج، هي الفكره كلها لما بتبقى ميزد كليبنج ممكن توصل بعد الكيموثيرابي ان احنا عندنا الليجن بيبقى مش موجود، او احيانا حتى مش بقدر اشوف في بارينكيمال ديستورشن. فبعدين لما تيجي تدخل الاوبراتيف بيد انا مش ببقى شايفه حتى بارينكيمال ديستورشن، يعني حتى عشان نركب واير مثلا على الليجن مش بنقدر شايفين خالص، فمش بقدر احدد نفسه الليجن نفسه اوكي كان موجود في المنطقه دي، بس البوردرز نفسها بتاعته او مكانه نفسه من فين لفين، من النبل او من السكين، دي حاجه احنا ما نقدرش نحددها احيانا بعد الكيموثيرابي. في ناس فعلا بيحصل كومبليت ريسبونس على الكيموثيرابي. فالكونتراست انهانس ماموجرافي بيخدمنا جدا في النقطه دي، ان لما بتيجي هقدر يعني خلاص يعني لما بتيجي تعمل كونتراست الجزء اللي موجود ده اللي مش واضح عندي في السونار ولا حتى في الماموجرافي بيبقى واخد انهانسمنت، فعلى الاقل اقدر ان انا احدد اشوف الليجن نفسه من فين لفين، او الجزء اللي موجود دلوقتي بعد الكيموثيرابي ده اللي هيتشال بعدين اقدر اعرف هو من فين لفين، حتى عشان اقدر ان انا اركب واير بعدين يبقى جايدد للسيرجري. فدي بتفرق معانا بعد كده في حالات البيشنت اللي بيبقوا ميزد كليبنج وبيبقوا واخدين كيموثيرابي في كومبليت ريسبونس على الليجن.
تمام، بس انا اقصد اقوله ان
يبقى ما فيش فاليديتد اللي انا
ان
افهمه
الام ار اي ممكن في وقت من الاوقات ممكن كان معمول ستاديز على الكورليشن ما بين الام ار اي ريسبونس كرايتيريا والباثولوجيكال كومبليت ريسبونس على الاكزامينيشن اوف سبيسيمن. في داتا زي كده ما بين الكونتراست انهانسد ماموجرافي وكمان الاسسمنت اوف باثولوجيكال ريسبونس. يعني اقصد اقول انا اقدر اريلاي على الحاله دي انها او تديني زي بريدكشن انها كومبليتلي ريسبونسيف على الكيموثيرابي على مستوى التيشو.
تمام.
الداتا كانت، انا بقول ده ممكن يبقى فيفرنج الام ار اي في الاسسمنت اوف ريسبونس. انا عارف طبعا الافيلابيلتي اقل
الMRI بالضبط
وطبعا
مش
الكوست
available.
عالي وكل
تمام.
حاجه، بس ده ممكن يبقى فيفرنج الام ار اي عن الكونتراست انهانسد ماموجرافي في منطقه الباثولوجيكال كومبليت ريسبونس. ده كانت
الفكرة
ماي
بس زي
بوينت.
ما حضرتك قلت إن هو الفكرة إن الMRI مش ما هوش available في كل الأماكن، طبعًا الcost بتاعته عالية
تمام،
والtiming طبعًا بيبقى
والافيلابيلتي
حجز
طبعا
وبتاع، لكن
والاكزامينيشن اكتر، وقت الاكزامينيشن اكتر.
بالضبط.
انتوا ممكن تشتغلوا عليها تفاليديت اللي حضرتك شفتيه بعد الكيموثيرابي على الريزلت اوف باثولوجي،
بالظبط
تمام.
ويبقى عند حضرتك بري كيموثيرابي الماموجرافي اهو،
بالظبط.
بوست كيموثيرابي الماموجرافي اهو، الباثولوجي اهو.
ان احنا نقدر
تمام.
نوصل زي نوموجرام او زي بريدكشن موديل، شكل المورفولوجي بعد الكيمو هيبقى عامل ازاي، وبعدين
اللي
اكوريليت
يتطابق مع
دوت
الباثولوجي.
مع الباثولوجيكال ريسبونس.
أوكي، تمام.
سؤال، هو الكونتراست ايه؟ ايه اسم الكونتراست؟
الcontrast اللي إحنا بنستخدمها اللي بتبقى هي أي مادة عمومًا whatever كان الشركات اللي موجودة، بس هي الفكرة إن هي بتكون non ionic. في يعني في ممكن حابب نستخدم
CT
الصبغة
contrast.
بتاعة اللي هي CT contrast،
تمام.
وحابب نستخدم برضه
الحاجة التانية،
آه.
في يعني التشاينيز جايد لاينز
مم.
خلاص اوبسوليت الماموجرافي فور ايرلي ديتكشن اوف بريست كانسر، علشان هم عارفين ان الفيميل تشاينيز هاف ا فيري دنس بريست تيشو، سو زي ار ريكومند بريست التراساوند. هقدر اقول دلوقتي with contrast لا ارجع للماموجرافي تاني، ولا برضه هيبقى عندي ميزد ليجن؟
لأ، إحنا طبعًا بنستخدم السونار برضه بيبقى بالنسبة لنا أكيد بنستخدمه في حاجات برضه بنرجع له، بس إحنا يعني هو الفكرة إن إحنا بالنسبة لنا إن إحنا بنعمل ال2D الأول، بنبدأ بال2D العادية، الimages الماموجرافي العادية جدًا. في lesions أوكي، يعني أنا دلوقتي فكرة إن أنا باقلل مثلًا فكرة إن أنا آخد biopsy من benign lesion. يعني أنا في عندي lesion دلوقتي وأنا مش sure إذا كان دي مثلًا أحيانًا كتيرة بيبقى في fibroadenoma بيبقى فيها نسبة شك إن هي ممكن لأ، إن أنا أسحب منها biopsy. فلأ الكونتراست انهانس ماموجرافي هيقلل البيشنت، العدد بتاع البيشنت عموما اللي انا اقدر اسحب منهم بايوبسي. فخلاص انا عملت لها كونتراست، ودي مثلا مش واخد انهانسمنت او واخد باترن انهانسمنت بتاع بناين ليجن، فخلاص نوت نيد فور بايوبسي يعني.
شكرا دكتوره ريحان.
شكرا يا دكتور.
هتقدم انت دكتور محمد؟ لا قدم.
دكتور حمدي اتفضل. سكند توك استاذ دكتور حمدي المراكبي، استاذ جراحه الاورام في المعهد القومي للاورام ورئيس وحده البريست، واستاذ زائر في معهد اورام قنا. التوك about breast reconstruction update.
Thank you, Mr. Chairman. Thank you, the inviting chair of the whole thing, Dr. Arim, my friend. I'll talk swiftly about breast reconstruction with an updates should be 2022. This sort of talk I mostly do it every year, and every year I rechange it and reformat it, because events are rapidly escalating towards reconstruction with different techniques. So what I see today, what I say today would be different in a few months' time, and of course it will be different from what I have said last year. Nothing to disclose. There is a vast spectrum of treatment of breast cancer, we all know, starting with wide local excision up to total mastectomy with or without reconstruction. For instance, for a small lesion, you can do wide local excision, for such as this patient who had a lesion wide by 1.2 centimeter. You treat the axilla, as we know. If it is negative, we do sentinel node biopsy. If it is positive, we may have to stage the disease and know if this patient needs to take neoadjuvant chemotherapy or not, or if it is luminal, you may go for excision plus axillary clearance. step forward with larger size defects, we can do what we call breast remodeling or glandular flaps reconstruction, such as this patient who had a lesion in the upper outer quadrant, 2.5 by 2.5 centimeters. She was 35 years old, and we do an excision. Most of the breast flaps or parenchymatous flaps are lying in the area between 20 and 50% breast defect, less than 20% breast defect, where you can model the breast tissue around and close the defect as it is. So that is a specimen, and that what you do with the breast tissue itself, such elevating the tissues around and close it all around. You may opt to excise a piece of skin as well here to end up with something like that. With larger defects that amount for 20 to 5% of the breast, you may have to do either one of these two novel techniques, such as volume replacement or volume displacement, depending on the size of the breast and the size of the breast lesions that has been excised as well. For larger breast ptotic, you can do what we call volume displacement. For small or medium-sized breast, you do a volume replacement with a variety of techniques, such as this patient who had an excision of breast lesions in the superior area here, superior to the areola, about 12 o'clock. You've done it in a separate incision, and we did an axillary dissection through a lateral chest wall incision together with a mini LED flap to cover the lateral defect that has been laid around here. So that's the mini LED flap. Nowadays, if something new I have to tell, I tend not to do the mini LED flap as so much, as there are alternatives such as perforators flaps, thoracodorsal perforator, lateral intercostal perforator, and sometimes we do lipofilling as well in a certain percentage of patients. All these things are very satisfactory with partial breast defects. Volume displacement. If you have something, a patient with a large ptotic breast and have a defect that amount for 3 by 3 centimeter, particularly supraareolar, he can do what we call it volume displacement based on the breast reduction technique that has been documented and referred to the literature in many situations. Of course, I cannot discuss how the techniques has been done, but at least you can make things happen. If you have a lesion that has been here, I think this patient had a right breast cancer. So if you have a lesion in the right breast in this area, you exploit and utilize an inferior pedicle technique where you move the nipple and areola after excising the defect here. This is a post-operative photo. I don't have the pre-operative photo, but that's a general outline on the method of reconstruction that you can do to cover the defects that amount for 20 to 50% of the breast tissue in a patient with a large ptotic breast. What about total mastectomy and skin-sparing mastectomy? Skin-sparing mastectomy is being described and indicated initially for extensive multicentric disease or minimally invasive breast cancer. Nowadays, we use it post-neoadjuvant chemotherapy. There was a question marks to do or not to do skin-sparing mastectomy after post-neoadjuvant chemotherapy. The guideline says that it is the same as patients who haven't had preoperative chemotherapy, I mean multicentric disease, blah, 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 and who have been given either chemotherapy or chemotherapy with Herceptin. You go back and you decide initially from the first MDT that this patient is a multicentric, and after she finished the chemotherapy, she will need skin sparing or nipple sparing mastectomy. And of course, if you do both or either, you will need to do a breast reconstruction. So that's something that has been established nowadays. It was not in the 10 years back. For instance, this patient had a skin sparing mastectomy in the left breast. And we used what we call it extended LED flap reconstruction. There is no time to describe the technique, but it's something very handy. Actually, this patient, if I see this patient now, I would try to persuade her for something like volume displacement because she has a large, very large ectotic breast. But in this particular situation, when the patient didn't like to do a symmetrization operation on the other side here, we opt to do a latissimus terza, and she was convinced that this might be the case for her. And as you can see, it ended with a very good results with adequate symmetry in both sides. So this patient had an extended LED flap reconstruction after skin sparing mastectomy. Of course, when the tumor is close to the nipple, not the areola, because some patients tend to have a wide area where the tumor is more than 2 centimeters away from the nipple. In such situation, you can do, if the lesion is close to the nipple, or if there is an extensive endoreductive component, you have to excise the nipple and the areolar disc around it and do a skin sparing mastectomy and LED flap or other variety of reconstructive procedures that we might discuss in the next few slides. So the nipple sparing versus skin sparing, there was a debate. Nowadays, it has been solved. You need at least 1 to 2 centimeter distance from the nipple, so not to include it in the excised specimen. And you can do a frozen section of the undersurface of the nipple as a margin. There are different approaches of nipple sparing mastectomy: periareolar, areolar and radial, lateral and infralateral, and inframammary. And each approach has its merits and its indications as well. For instance, this patient had an inframammary approach, which is not seen here, and you put an implant, and it gives her a very good cosmetic results. After radiotherapy, this will go down and will be kind of similar to the other side. As a matter of fact, this patient asked me to enlarge her breast here, and I rejected that because she would have had radiotherapy that will do the job for us. Nipple sparing mastectomy and LED flap with circumareolar incision around here. Skin sparing mastectomy with retroareolar or supraareolar with radial extension. That is, you can see the extension radial here to complete the skin sparing mastectomy procedure. So what would be different from the past? Again, we offer skin sparing and immediate breast reconstruction for our patients who have had neoadjuvant chemotherapy, such as with the same indication of reconstruction prior to radiotherapy, prior to chemotherapy. What about breast reconstruction after modified radical mastectomy? Why? Because of many things, and because also of the availability of a variety of techniques. There are psychological benefits, as you know, better quality of life that you used to say. I enjoyed the session this morning where our colleague here was saying we always focused in what treatment, what's something this patient should be done, and we don't focus much on the quality of life that patients have had. So nowadays, no patient should be abandoned from the reconstructive technique, whether prior to treatment or after treatment. You should discuss it, you should counsel the patient, you should do whatever convenient and feasible. particularly with the use of immediate delayed breast reconstruction that I will talk about next. So, as I said, no patient should be abandoned breast reconstruction even following MRM. Immediate delayed reconstruction with an expander, as I mean implants expander, is an excellent option for those who demand breast reconstruction. In this situation, we put the expander, we start to fill it after 2 weeks from surgery till 6 months. During that period, this patient will have had a radiotherapy treatment and then come back for a definitive reconstructive method. And the advantage of this is you keep the skin envelope healthy for further reconstructive procedure. You give the patient hope that she will have had reconstruction in due course. And that will be the starting point for her, is to start doing something while she's having treatment. And once she finishes her treatment, you give her another reconstructive option which might suit. So in the right-hand side, this is the expander that we start to fill it 2 weeks after surgery, and that's the definitive implant. So with regard to the timing, well, again, we know all the advantage of immediate reconstruction and all the disadvantages as well. But again, the thing of putting an expander have solved this. For instance, if you like to preserve the skin envelope which is healthy, the expander will do it. If you want to have an easier dissection of the flap in a delayed reconstruction, the implant or the expander will do it. And you still can define the inframammary fold, which will give the breast mold its shape, size, and projection. The late reconstruction, again, we don't put it like that in advantage or disadvantage. We do delayed reconstruction for patients who initially presented with T4 breast cancer or advanced breast cancer, because we think that the life expectancy will be not much, because we think that the adjuvant treatment is mostly needed in this situation. And we persuade the patient just to wait for a year or so till she finishes her whole treatment. And the advantage with that will be that the treatment has been completed and there is plenty of time to think about it. There is no much fear of local recurrence, and she will have a realistic expectation because she will have her breast excised and flat, and then once you do something for her, she will be happy. Again, with the tissue expander, with an implant expander that you put immediately after MRM, the patient will think that something is getting well, as done, and she is in due course, and she is on the line of further management, particularly with the reconstruction. We talked about the implant. Implants are very useful for small volume reconstruction, such as a small or medium-sized breast, or in patients who had initial T4, where you put an expander, as said. With bilateral breast reconstruction, that is excellent method, because you put similar sized implants on both sides, and the size match will be excellent. The downside of that that the implants usually hasn't got a long life reconstruct. It's not a long life reconstructive method. You need a skin flap quality, and it's not a good option with or without chemotherapy. So the implants, again, I know they are running out of time, but the new thing, if I have new things, we put an implant nowadays. We don't have to put it under the muscle. You wrap it with what we call it Ultra Pro mesh, and the Ultra Pro mesh protects the implant from moving lateral and medial, and so it is sort of fixed. So it prevents the animation defect and keeps the structure of the implant in place. However, capsular contracture with or without Ultra Pro mesh will be the same, which is about 30%. It is a very good instance. That's the case of bilateral breast reconstruction with silicone implants. Complications of implants such as infection, rupture, and capsular contracture is not small. The last thing in the talk, which is the biggest one, I wouldn't be able to cover it, but I will go swiftly above it. The breast reconstruction with flaps. There are a variety of flaps that can be used, particularly the LED flap, which is the gold standard in breast reconstruction. That patient had an LED flap. Personally, if one of my colleagues, the surgeon, asked me, do you divide the tendon? Yes, I divide the tendon. Do you divide the nerve? No, I don't divide the nerve. I divide the tendon because I don't like lateral animation. I don't divide the nerve because I need to keep the integrity and the volume of the flap. Once you divide the nerve, particularly if this patient have radiotherapy, you lose about 1/3 of the flap. That's an accidental. There's no place to mention it, but it gives you a very large volume, particularly such as this patient. As I told you, this patient should have had an breast reduction, therapeutic mammoplasty in this side, and reduction mammoplasty in the contralateral side. She didn't like that, and she wanted to have a flap from her back. We did that with extended latissimus, and it turned out to be a nice setting. The tram flap is the gold standard. We know all about it. Pedicle, the free, superjar, and the free flap. It gives the most natural fat to the breast tissue. If you see a patient with a breast reconstruction with a tram flap, you will see subtle bubble breast fat that matches the contralateral side. Pedicle, the flap based in the superior epigastric. That patient had a pedicle tram flap based in the superior epigastric. It is a very useful. Each method of reconstruction has its own merits, but that's one of the things that is very useful and give you size match and texture match to the breast. It is relatively an easy technique. No need for microsurgery. Rapid recovery, less cost, disadvantage, more vascular complications such as fat necrosis and partial flap loss, donor side morbidity, difficult breast shaping. These all things, you have to keep it in the context of the reconstruction, and you need to discuss what patient need. Nowadays, we have more patient demanding breast reconstruction, and so they will accept surgery to the contralateral breast, and so you can play around with different methods of reconstruction. In the old day, we did not have this leisure. Patient didn't like surgery to the contralateral side. Patient didn't like silicones or something like that. So we've been cornered in the reconstructive method and technique. Free trams, more robust vascularity, much easier shaping, less donor side morbidity, but it is all or none, and you may end up with failure that amount to partial or total loss of the flap because of some bad techniques or bad patient selection. This patient had a DIAP flap. As you can see, the muscle integrity is still there, medial and lateral, and you follow the perforators to the skin, paraumbilical perforator, and then down to the inferior epigastric artery. You excise the whole bit there, and you move it to the breast, and then anastomose it to a suitable artery and vein in the breast. Nipple and areola, I'm not going to talk about nipple and areola, but there are also a variety of technique in reconstructing the nipple and areola. I brought this picture just to show you how evolved and developed our techniques nowadays. For this patient who have had breast reconstruction using a free tram flap, and she came demanding nipple and area reconstruction, such as a V-shaped flap, and then a reduction mammoplasty was done on the contralateral side. This kind of patient would not be available 10 years back because he didn't like to have, they like everything as one-stop surgery. Nowadays, you will accept going for several types of several procedures to achieve the required symmetry. So finally, we have to understand that breast reconstruction is not a single procedure. It is individualized based on the disease and the defect. And there is nothing like one size fits all. Patient counsel and expectations are important before contemplating such surgery. What is new in this lecture is many immediate delayed or delayed reconstruction nowadays, more implant-based reconstructions that we adopt, more perforated flaps for partial breast defect rather than latissimus or mini latissimus, more skin sparing after neoadjuvant chemotherapy and immediate reconstruction. And even with some complications at partial nipple and areola, you will have a good symmetry, as you can see. So you have this patient had been reconstructed, slight nipple and areola sloughing, but the overall everything is acceptable. With difficult situation like this patient who had an incision before for lumpectomy prior to reconstruction and chemotherapy, we still use the same incision that has been used before, not in our hands, and do an extended latissimus reconstruction would turn out to be a good option. Thank you.
Thank you, Professor Dr. Hamdi Meraghbi, for this clear, concise presentation. هنستأذنكم ممكن نخلي الأسئلة علشان الوقت بعد المحاضرات علشان تدخل المحاضرات مع بعض.
شكرا دكتور حمدي على المحاضرة القيمة. Now I have the pleasure to introduce my friend Dr. Muhammad Ali, professor of Medical Oncology Mansoura Cancer Center. He will talk about triple negative breast cancer, early and advanced disease.
السلام عليكم بسم الله الرحمن الرحيم طبعا I'd like to thank Professor Reem for this very nice event and organization. Also many thanks Mr. Chairman for kind introduction. My talk will be on triple negative breast cancer, both early and advanced disease. Historically, we know that triple negative breast cancer usually has a poor prognosis in relation or in comparison to other type of breast cancer with high risk of relapse, especially in the first 1 to 4 years after surgery or after adjuvant therapy. Also, we know that nowadays we have many new definitions as survival. This will be my first part in my talk about the early triple negative breast cancer with some new advances in the management. The outcome is strongly correlated with the pathological complete response after the neoadjuvant chemotherapy. And we can find that the patients with the residual disease and triple negative usually behave poor or have the poorest survival in comparison to the other type of breast cancer, either achieving BCR or not. So we have a rationale for the post-neoadjuvant setting in order to improvement the survival of these patients. PCR is a validated endpoint for triple negative breast cancer in the early stage, and residual disease usually suggests a resistance disease, questioning to use a further drug or a further molecule in the adjuvant setting to overcome this resistance. And so you can elongate or improve the overall survival and the event-free survival of your patients. I know that all my professor and colleague know about this study, which is the tailored chemotherapy escalation in the residual disease for HER2 breast cancer patients, which is a Caryatix study that randomized the patient after surgery who do not achieve the BCR either to receive capecitabine or no. For the triple negative breast cancer cohort, you can find the very nice improvement in the disease-free survival and the overall survival in the experimental arm. I mean by adding capecitabine in the adjuvant setting for 6 months. And this result was better in the hormone negative rather than hormone positive breast cancer patient. The dilemma for adding immunotherapy or the rationale for using immunotherapy in the early triple negative breast cancer, I think you can, from this cartoon, find with more and more advanced, you may have an immune escape for the tumor. I may introduce immunotherapy as early in the early setting, and I can get a good result or a good benefit. This rationale was proved from the two famous studies all of us know, the Keynote 522 and the Impassion 301. The first one, randomizing the patient to receive neoadjuvant pembro plus chemo, then after surgery continue adjuvant, and the other one, atezo plus nab-paclitaxel, then in the adjuvant setting continue atezo for about 1 year. This is the PCR rate achieved in the BOSS study. You can find a significant improvement in the PCR by adding immunotherapy to chemotherapy in the neoadjuvant setting. And this achievement or this benefit was maintained either in the BDL1 positive or BDL1 negative. Because again, I mentioned that in the early stage of the disease, you can have a good immunogenic media in the tumor, so you can give immunotherapy regardless of the BDL1 expression if you need to achieve a very nice PCR, which is one of the surrogate marker for the outcome in triple-negative breast cancer. So addition of IO to the neoadjuvant chemo can improve the PCR irrespective of the BDL1 status. Regarding the event-free survival, on your left-hand side, you can find that the very benefit improvement or the significant improvement in the event-free in both arms, I mean the patient that received IO and patient that not received, especially in the PCR cohort. But in the no PCR cohort, you can find a difference favoring the using of the IO. So now we have the upper two curves more or less similar to each other on achieving the PCR, but the addition of the IO can be reflected with a better improvement in the overall survival, either in the patient achieved the PCR or no. So totally, I can find that adding IO to the neoadjuvant chemo can improve significantly event-free survival and overall survival. Regarding the toxicity, I know that all my professor and colleague well known about the immune associated toxicity or immune mediated toxicity with the immunotherapy, which is maybe augmented in the combined phase, I mean in the neoadjuvant setting, but however, you can find a decrease in this toxicity in the adjuvant setting because the chemotherapy did not added in this stage. When adding immune checkpoint inhibitor to neoadjuvant chemo, you can improve the response either in the nodal positive disease as the same as nodal negative disease. What about the rule of adding the PARP inhibitor in the early triple-negative breast cancer? This question was answered by the Olympia study that randomized the high-risk triple-negative breast cancer. I mean, the patient did not achieve the BCR after neoadjuvant chemo or from the start with stage 2 or stage 3 breast cancer with germline BRCA mutation, PRCA1 and 2, to be randomized after chemotherapy and after surgery to receive 1 year of PARP inhibitor, which is olaparib versus placebo, and you can find the improvement in the hazard ratio regarding the IDFS, invasive disease-free survival, and overall survival with hazard ratio 0.63, which is mean about 37% reduction in the risk of progression and reduction in the risk of death. So 1 year adjuvant olaparib after completion of the local therapy, whether neoadjuvant or adjuvant and surgery, you can improve the survival of your patients in case of germline BRCA1 or BRCA2 mutation. About the dilemma for adding platinum for the early triple-negative breast cancer, all these meta-analysis confirmed that we have an improvement in the BCR, we have an improvement in the DFS and overall survival by adding the platinum group. But however, regarding the recent NCCN guideline, you can find that these molecules are added in the treatment of early triple-negative breast cancer, especially in the neoadjuvant setting. We have no proven data to use platinum in the adjuvant setting. Use of the platinum agent in the adjuvant is not recommended, but in the neoadjuvant you can use if you need to augment your response regarding the BCR in the early triple-negative breast cancer patients. So I can summarize the management for early triple-negative breast cancer in this slide. On your left side hand, you can find the how to deal with a small tumor with node negative disease less than 2 centimeter. I know there is no problem with this group, but what for the patients have tumor 2 centimeter or more and node positive? The recent guideline stated that you will start neoadjuvant chemo with IO like pembro or atezo, and then after surgery, if your patient achieving a PCR, I think you will continue for 1 year IO, either pembro or atezo. But the problem in the other group, the patient did not achieve the PCR. We have many options for these patients. Regarding the BRCA wild type, you have two options. Either to give capecitabine, or if you offer the patients IO in the neoadjuvant, I think you must continue 1 year pembro plus minus cap or pembro, then capecitabine. We have many questions regarding this point. For patients with BRCA mutation, you have also a dilemma either to use PARP inhibitor alone or to combine pembro or IO plus PARP inhibitor, or to give IO 1 year, then to go for PARP inhibitor for another 1 year. There are many studies ongoing nowadays aiming to answer this question, because this is the dilemma for the patient did not achieve the BCR in early triple negative. This was my first part of my talk. Let me talk about now the advanced triple negative breast cancer, and also I will try to summarize. We know that metastatic triple negative breast cancer is usually associated with poorer outcome in comparison to the other group or other type of breast cancer. You can find the median overall survival for metastatic triple negative about 14 months only, versus the other group can reach up to 44 median overall survival. So we have a problem again regarding the metastatic triple negative breast cancer. First, these are the chemotherapy molecule that approved in many guidelines like ESMO. In chemo-naive patients, I think anthracycline and or taxane is one of the standard of care. In case of taxane naive or anthracycline previously received, or patients who achieved or received the maximum dose from anthracycline or have a cardiotoxicity, you have another option like taxane capecitabine. For patients that received both anthra and taxane before, I think also you still have option for chemotherapy like liposomal anthra, like capecitabine, eribulin, or the platinum compound. What about the pattern for sequelae for giving the patients chemotherapy in metastatic triple negative? This study randomized the patient either in the first arm to receive platinum, then upon progression docetaxel, and the other arm the reserve docetaxel, then upon progression the platinum group. As there was a difference between these arms, in all patients there was no any difference, but regarding the patients with BRCA1 mutation, I know that all of us will know that in this group of the patients, the platinum will be do better or did better in these patients, with a significant favoring the start with the platinum, then upon progression docetaxel. But in case of no BRCA mutation, again, there was no any difference between treatment arm. And this question was in the ABC5 in case of metastatic triple negative patients that receive anthra and taxane. Carboplatin still demonstrated a comparable efficacy, and the answer was about 90% yes, you can use carboplatin compared to the taxane in case of progression on a previous anthracycline with or without taxane. For eribulin comparing to capecitabine, I know that this result well known to all our professor and colleague here. The eribulin was more good or did better than the capecitabine regarding the overall survival, especially in the metastatic triple negative breast cancer patients. Role of immunotherapy for treatment of metastatic triple negative. This study in patient 130 randomized the patient to receive atezo plus nab-paclitaxel versus nab-paclitaxel, but in case of PD-L1 expression by the special method SCP 142 assay. you can find much more benefit was in the patients with PD-L1 positive expression regarding the progression-free survival with a good hazard ratio about 37% reduction in the risk of death. Again, also in the updated overall survival, you still find a very nice improvement regarding addition of the IO for chemotherapy for metastatic triple negative. The same also in the Keynote 355 study, but with another method for detection of the PD-L1, which is the CPS, because here the patients will offer the Pembro plus chemo. Still, you can find an improvement significantly in the overall survival, especially in the patient with the CPS 10 or more, having 10 or more expression of the PD-L1 according to the CPS method of the detection, regarding the overall survival and also regarding the progression-free survival. I know actually the immune-related event will be more with the IO versus the chemotherapy alone. If there is a role of the PARP inhibitor in the management of the metastatic triple negative? Yes, the Olympiad study and the empirical study confirming this data, and the answer for this question, in case of germline BRCA mutation, the patient randomized either to receive one of the PARP inhibitor versus chemotherapy. Still, you can find here an improvement significantly in the progression-free survival, favoring the adding of the PARP inhibitor for this group of the patients. I know still we have an increasing some toxicity versus the other group or versus the chemo arm, like anemia, neutropenia, alopecia, and nausea. The recent advances in the using for ADC or antibody drug conjugate, the SCG was proven by the ASCENT study that randomized the patient after 2 or more chemotherapy line to receive the ADC versus the treatment choice, which is here the SCG or the cetuximab govitecan. You can find a significant improvement progression-free and overall survival. What about the low HER2, which is a new expression added for the triple negative? These are group of the patients that has some HER2 protein of the cell surface, but not enough to be classified as HER2 positive disease. In the Destiny study 04 breast study, this group of the patients randomized either to receive DXD versus chemotherapy, and here you can find a very nice improvement in the progression-free survival, either in the hormone-positive breast cancer patient or in the hormone-negative breast cancer patients. I think we will have in the future a very nice improvement by using this molecule some early or in early of the treatment of our patient. I can summarize now the management for metastatic triple negative breast cancer by this slide. In case of the PD-L1 positive expression in your left side hand, I think you can offer your patients the IO as a first line because it is not approved on later on. If it's available, you can use the IO in the first line setting. And also in case of BRCA germline mutation, you have an option for the PARP inhibitor or the platinum chemotherapy. In the other group, in your left side hand, or in your right side hand, in case of the PD-L1 negative expression and the BRCA germline mutation, you have a PARP inhibitor or the platinum, or in case of BRCA wild, you have the standard chemo, and sometimes bevacizumab plus chemo can be approved in some country. This about the first line. What for the second line? In case of the PD-L1 expression and the BRCA mutation, I mean the PD-L1 received in the first line. So now you have an option to receive the PARP inhibitor in case of the BRCA mutation. Otherwise, you will receive the chemo. The same in the other group of the patients. And with more and more progression, you will shift for the cetuximab govitecan, which is one of the recent the ADC. By this slide, I have finished my talk, and I hope I try to concise the management for triple negative breast cancer patient in one session. Thank you so much.
Thank you, Dr. Mohammed, for this comprehensive talk. I mean, this is wide range, the early and the metastatic disease. We will have questions.
You can postpone.
Okay, we'll postpone questions until the end of the session. Now we will have the pleasure to introduce Dr. Evram Asi, The topic will be a novel approach for HER2 patient, the trastuzumab deruxtecan, the presentation of the Destiny 04. Go ahead and try to start presenting, and we will let you know if we are hearing you.
Good afternoon from me. Thanks to the organizing committee. I am very happy to attend this conference, even if I am far away from Egypt, not so far away. To be honest, I am in Athens, Greece. So my topic will be a new standard of care for a new subtype of breast cancer, the HER2-low subtype of breast cancer. As you all know, recently, this year, we had the excellent news of Destiny Breast 4 that involves a novel treatment in HER2-low breast cancer patients. First of all, in the early 80s, it is about 40 years before, Dr. Dennis Lamon identified that about 25 to 30% of breast cancers were having an amplification of the gene for human epidermal growth receptor 2, leading to overexpression of the protein on the cell surface of breast cancer cells. This overexpression was associated with a much more aggressive disease biology and worse outcomes for patients diagnosed with breast cancer, regardless of the stage of the disease. About 3,100 cases only in the United States are being diagnosed annually, of which about 80 to 85% are those cases which are considered to be HER2 negative cancers, subtypes, and of which most of them involve the HER2 patients, as we know till now, that are explained by immunohistochemistry or in situ hybridization with the standards that we know, and triple negative breast cancer patients. These patients do not have too many copies of the HER2 protein on their breast cancer cells. This doesn't mean that they don't express it at all. Of that proportion, about 60% of patients are classified as being HER2 negative, but now they are considered to be HER2 low from 2022 and ongoing. The measurement of HER2 expression, as we all know, is done with immunohistochemistry and in situ hybridization. Now, the HER2 plus 1 by immunohistochemistry and the HER2 plus 2, which is in situ with the technique of in situ hybridization negative, are considered to be HER2 low. So, what is the background of this trial? In the recent years, the development of a new agent, the trastuzumab deruxtecan, has changed the treatment landscape for HER2 positive breast cancer. This agent targets the HER2 receptor on the cell surface of the cell, and it gives a cytotoxic payload inside the cell, which destroys the cell and lowers the breast cancer activity. This antibody drug conjugate shown a reported activity in earlier trials, and right now it is considered to be the drug of choice in patients with pre-treated HER2-low breast cancer, following the DESTINY-Breast03, which involved the HER2-positive patients. So as regarding with the trial, patients with HER2-low breast cancer are eligible for Enhertu if they have received a prior chemotherapy in the metastatic setting. The metastatic setting may be beyond, from second line and beyond, or it may involve patients that they progressed. They had they have been treated for adjuvant breast cancer, but they progressed within 6 months of completing adjuvant therapy. This approval is based on this trial, which is a randomized, multi-center, open-label clinical trial that enrolled 557 breast cancer patients, and the trial included 2 cohorts, 2 to 1, 494 hormone receptor positive patients and 63 hormone receptor negative patients with a 2 to 1 randomization of receiving trastuzumab deruxtecan or treatment of physician's choice, which is a series of chemotherapy selections as paclitaxel, navelbine, capecitabine, gemcitabine, or nab-paclitaxel. The results showed improvement in progression-free survival, in both progression-free survival and overall survival, in people with unresectable or metastatic HER2-low breast cancer, with a median PFS of 9.9 versus 5.1 months, and a median overall survival of 23.4 versus 16.8 months. The involve patients that were the median of age of them is 57 years old, ranging from 28 to 21 years of age. And of the 557 patients, 24% were age 65 or older. Of course, females, they comprised most of the patients, in a percentage of 99.6% of the whole trial population. And the trial participants were 48% white, 40% Asian, and 2% Black or African American, and 3.8% Hispanic or Latino. The prior therapies regarding the trial, most of the patients had more than 2 previous lines for metastatic setting, although a small minority had received one line as first line or 2 lines before entering the trial. And according to the prior therapies, these lines of therapies had involved CDK4/6 inhibitors and endocrine therapy, as well as chemotherapy in most of the patients. The PFS by subgroup in the hormone positive patients was positive. The PFS was in all subgroups noticed to be statistically significance. This involves the patients that had CDK4/6 inhibitors in the past, patients that had more than 2 lines of therapy, among all age groups, among all races, even in the small percent of African American and Hispanic Latino origin, and in patients that had visceral disease at baseline 2. This is very important. This is a breakthrough trial, and regarding the safety, we all notice that Enhertu, trastuzumab deruxtecan, is an agent that is more tolerated from our patients than the standard of care, the classic chemotherapy regimens with which it was compared, with a safety treatment of duration of 8.2 months versus 3.5 of the classic chemotherapy, and the drug-related events in the trial were noticed to be very well tolerated, with nausea, fatigue, alopecia, vomiting, hematologic discrepancies as neutropenia, anemia, etc., being present, but not at grade 3, most of them or more. They were very well tolerated. And another thing that we noticed from this trial is that trastuzumab deruxtecan has a specific side effect, which we find it in immunotherapy too, which is the incidence of pneumonitis, of which a very small percentage had grade 3 or more, but when we consider giving this agent, we always have to think of the possibility of our patient having pneumonitis and how we are going to manage it. Another thing is that it was noticed cardiac dysfunction in a small percentage of 4.6% with trastuzumab deruxtecan as well. In conclusion, this trial, which is a breakthrough trial this year, and involves HER2-low subtype patients, which is a new subtype for us all, introduced Enhertu to the treatment of these patients with a median PFS and an overall survival which are excellent. It's not something that we find usually in our trials. It's a breakthrough trial, and it is very notable that this drug worked well in all subtypes of patients, and that this drug was also very well accepted with very few side effects regarding to the treatment of choice, the classical chemotherapy, which till now is preferable than classical chemotherapy in the setting after the first line in these patients. Something that I want to note is that as well as in other trials, in other tumors, there are already working trials that are trying to incorporate this drug in earlier settings as the adjuvant and the neoadjuvant setting of breast cancer HER2-low patients. And I am sure that in the future we will find it in in earlier settings than the metastatic setting right now. The point and the target for all our therapies is giving more life and a better quality of life to our patients, but prevention is better than cure, as we all know. Thank you for your attention.
Thank you so much, Professor Ibrahim, for this elegant presentation. I know you are online. If there is any question, we can ask. Okay. Thank you so much. And we go now. We proceed for the next speaker. Let me present our dear colleague, Dr. Fatma Ibrahim from Mead Ghamr Cancer Center. She's going to talk about metastatic HER2-positive breast cancer. Welcome, Dr. Fatma. The floor is all yours.
Good evening, everyone. Thanks for OncoEgypt for your kind invitation for first time. My talk today will be about metastatic HER2-positive breast cancer. My agenda will be about established first and second line therapies, new oral tyrosine kinase inhibitors, antibody drug conjugates, and new engineered antibodies, and what about new directions. To understand HER2 anti-targeted therapy, we should understand HER2 signaling pathway. When one or more specific ligands bind to tyrosine kinase domains, it will lead downstream signaling and activation of one of two pathways, BI3K ACT pathway or RAS-MBK pathway. So it will lead cell proliferation and breast tumorigenesis. Targeted therapy for HER2-positive breast cancer, we can see from this diagram according to biology and structure. HER2 targeted monoclonal antibodies, trastuzumab and margetuximab, bertuzumab, HER2 and HER3, HER2 targeted antibody conjugates, TDM1, and trastuzumab deruxtecan. The prognosis of HER2 disease is poor regarding in comparison to luminal A, luminal B, and basal subtypes. And there is a recommendation from NCCN guidelines regarding first and second and third lines. We can see that bertuzumab, trastuzumab plus taxane is the first line accepted, category 1. Regarding second line, trastuzumab deruxtecan and trastuzumab TDM1, and other lines including labetinib, neratinib, and tucatinib. Regarding historical content targeting and HER2 metastatic breast cancer, we can see that adding just trastuzumab to chemotherapy has greatly improved significantly progression-free survival, and there was improvement overall survival, but this difference was not statistically different. Trastuzumab has changed the natural history of HER2-positive breast cancer, now have comparable outcomes with HER2-negative metastatic breast cancer. Resistance to trastuzumab, both primary and secondary, is a major clinical concern. 50% no response, median progression-free survival about 12 months. So delaying resistance to trastuzumab and future HER2 targeted therapy and treatments that overcome resistance are needed. So questions: when do we define definitive resistance to trastuzumab and continuing it through progression, mechanism of resistance, ways of overcoming resistance. Bertuzumab and trastuzumab complementary mechanism of action. We can see that trastuzumab inhibit ligand-independent HER2 signaling and activate antibody-dependent cell-mediated cytotoxicity and prevent HER2 extracellular domain shedding. Bertuzumab inhibit ligand-dependent HER2 dimerization and signaling and also activate antibody-dependent cell-mediated cytotoxicity. Based on phase 3 Cleopatra study, bertuzumab has been approved as first-line treatment in association with taxane and trastuzumab. Regarding Cleopatra study design, she studied two comparable arms, bertuzumab, trastuzumab plus docetaxel or placebo plus trastuzumab docetaxel. We can see here significant improvement in median progression-free survival, about 18 months in the arm received the bertuzumab, and also significant difference regarding median overall survival. And this difference was statistical difference with hazard ratio 0.6, which means that at least 40% show low risk of disease progression. Are all patient candidates for dual HER block?
Most patient will be eligible for bortezomib, trastuzumab plus ataxine, and treatment must be individualized. Patient with decreased left ventricular ejection fraction are not candidate cases in which taxine may be replaced, in which patient with pre-existing neuropathy or patient who relapsed within 6 months of complementary adjuvant regimen containing trastuzumab and taxine. Another single-arm phase 2 study of bertuzumab plus trastuzumab and weekly paclitaxel in patient with HER2-positive metastatic breast cancer. We can see preliminary 6 months progression-free survival rate about 76%. And regarding safety data, no unexpected or cardiac event regarding toxicity. We do know continued HER2 blockage after progression on trastuzumab is beneficial. Regarding an examples of 3 trials, continuation trastuzumab plus capecitabine in comparison to capecitabine alone has showed improved time to treatment progression and overall survival. And also trastuzumab alone versus no trastuzumab at a third line showed a survival benefit. Capecitabine plus labetinib in comparison to capecitabine alone showed improvement time to treat progression was statistically significant, and improvement in overall survival, but this difference was not statistically different. Regarding TDM1 mechanism of action, we can see when TDM1 bind to subdomain of HER2, it would lead receptor internalization and by lysosomal reaction, intermethrin release and inhibition of mercury polymerization, and so cell apoptosis and death. Early data was encouraging regarding overall response rate with about 34%, and the median progression-free survival was about 7 months, and acute toxicities were tolerated. TDM1 versus capecitabine plus labetinib regarding phase 3 EMILIA trial. We can show significant improvement in progression-free survival with hazard ratio of 0.6 as regard 40% of patients show low risk of disease progression, and this difference was statistically different. Regarding response rate were higher in TDM1 arm, about 43.6% in comparison to capecitabine plus labetinib alone. Regarding another subgroup analysis in phase 3 EMILIA trial, we can show regarding hazard ratio, TDM1 show better results. Regarding median overall survival in TDM1 group was about 30 months in comparison to capecitabine labetinib. This difference was higher and statistically significant. Clinicians should recommend the combination of trastuzumab and trastuzumab and taxane for first-line treatment unless patient has contraindication to taxanes. If a patient is HER2-positive breast cancer and has progressed during or after first-line HER2-targeted therapy, clinicians should recommend TDM1 as second-line treatment. If patient HER2-positive advanced breast cancer has progressed during or after second line and she has not received TDM1 before, should offer TDM1. Another open label randomized phase 2 study of TDM1 as first line of treatment in patient with HER2-positive metastatic breast cancer compared to TDM1 in comparison to trastuzumab plus docetaxel, we can see that overall response rate was higher in TDM1 than trastuzumab plus docetaxel, and adverse event will less in TDM1 group. Other phase 2 studies started TDM1 plus paclitaxel and trastuzumab in patient with HER2-positive metastatic breast cancer. There was no significant difference in response. EMILIA retrospective exploratory analysis TDM1 versus labelinib and capecitabine in HER2-positive metastatic breast cancer and CN metastasis. We can see that median progression-free survival there was no significant difference, but median overall survival was higher, and differences was not statistically significant regarding CNS metastasis. What is new in HER2-targeted agent? Another HER2 TKIs, neratinib, tucatinib, HER2 antibody conjugate, trastuzumab deruxtecan, and ducarmazine. Engineered HER2 monoclonal antibody margetuximab. HER2 TKIs for preventing or treating brain metastasis. About more than 50% of patients with HER2-positive metastatic breast cancer will develop brain metastasis. Labetinib plus capecitabine is approved an option in setting, but few patients respond, with overall response rate about 21% and the median progression-free survival of about 4 months and overall survival of 11 months. Neratinib and plus capecitabine has approved for this setting with CNS metastasis, and overall response rate was about 33%. TDM1, trastuzumab, and bertuzumab don't penetrate CNS under normal condition. This HER2 register analysis, progression and overall survival by CNS metastasis HER2-positive metastatic breast cancer, we can see that median progression-free survival and overall survival were worse in this group. Regarding cerebral trial, CNS metastasis at first relapse in HER2 positive metastatic breast cancer with labetinib plus capecitabine versus trastuzumab and capecitabine, but this trial closed early for futility in labetinib plus capecitabine arm. Another phase 3 trial, labetinib plus or minus trastuzumab in heavily pretreated metastatic breast cancer following progression on trastuzumab. We can see there was improvement on adding labetinib to trastuzumab, median overall survival about 14 months, and this difference was statistically significant. Another recommendation from Journal of Clinical Oncology for patient whose systemic disease is not progressive at time of pre-metastasis diagnosis, systemic therapy shouldn't be switched. For patient whose systemic disease is progressive at time of metastasis diagnosis, clinician should offer HER2 targeted therapy according to the algorithm of treatment HER2 positive metastatic breast cancer. If patient doesn't have known history or symptom-free metastasis, routine MRI should not be performed. Neratinib, regarding mechanism of action, we know that it is a pan-HER2 tyrosine kinase inhibitor, a reversible inhibition, another different mechanism of action than trastuzumab and bertuzumab. Regarding NEFRIT trial, it showed that number of event-free of CNS metastasis was the patient who developed CNS metastasis was less in number in the arm received neratinib plus paclitaxel versus trastuzumab plus paclitaxel. Another CRC trial, single arm phase 2 stage study of neratinib plus capecitabine in HER2 positive metastatic breast cancer with CN disease. It showed over response rate with about 33% in patient with prior treatment with labetinib. NALA trial, neratinib plus capecitabine versus labetinib plus capecitabine in HER2 positive metastatic breast cancer with more than 2 prior lines for HER2 anti-targeted agent. We can see there was significant improvement in progression-free survival and overall survival. Regarding tucatinib, it is HER2 selective tyrosine kinase inhibitor, less EGFR associated toxicity than other HER2 targeted tyrosine kinase inhibitors, CNS penetration, well tolerated and active in combination with CDM1, capecitabine, or trastuzumab. Phase 1B study, tucatinib plus capecitabine, trastuzumab in HER2 positive metastatic breast cancer. It showed over response rate about 61%, and CNS metastasis also showed high response rate about 42%. HER2 CLIMB study, it's about tucatinib plus trastuzumab plus capecitabine in previously treated HER2 positive metastatic breast cancer. We can see that risk of progression of this was reduced by about 46%. Progression-free survival improved from 5.6 to 7.8 months. Over response rate was also improved from 17 to 21%. Risk of progression of this was reduced by 52% in patient with brain metastasis. Progression-free survival by hazard states was greatly improved, and this different was statistically different. Also, regarding our overall survival status, it is also greatly improved with high overall survival in hormone-negative subgroup show higher overall survival probability than other subgroups. New oral pan-tyrosine kinase inhibitor, pyrutinib with capecitabine in HER2 positive metastatic breast cancer, capecitabine plus pyrutinib. It showed progression-free survival improved from 11 up to 11 months, improved over response rate, primary toxicity about 31% with grade 3 diarrhea, and about more than 98% all grades, increased mucositis and count suppression. Another phase 2 trial of positinib in pre-treated HER2 positive metastatic breast cancer patient, primary toxicity was about 30% grade 3 diarrhea, less than 6%, 100% grade 3 mucositis, rash, and mucosal inflammation. Another HER2 targeted antibody conjugate, trastuzumab deruxtecan. It's a high drug antibody ratio, humanized anti-HER2 IgG1 monoclonal antibody with the same mechanism of action sequence as trastuzumab. More stability, tumor selectable cleavable linker, high potency, and bystander killing defect. Regarding destiny trial, BREST-001, trastuzumab deruxtecan in advanced HER2 positive breast cancer and metastatic breast cancer, especially HER2 low patient. In this patient, HER2 protein, some HER2 protein expressed over cell membrane, but not sufficient to determine that it is a HER2 positive patient. We can see that over response rate about 60%, and the median duration of response is about 14 months, and the median time to response about 1.6 months. There was a greatly improvement in progression-free survival and overall survival about after 20 months median follow-up. Margetuximab engineering alerts FEC receptor affinities and activate the immune response. Margetuximab has the same specificity affinity to HER2 trastuzumab with similar ability to disrupt signaling. However, with intent to activate immune responses, margetuximab have an altered FEC receptor affinity. Evolution of HER2 low between primary and metastatic breast cancer. HER2 reached in metastatic breast cancer was compared with primary 50% versus 42%. Later relapses had higher reactive increase compared with early relapsers. Pathways, another summary treatment algorithm in HER2 metastatic breast cancer is trastuzumab, taxane, pertuzumab, the first line, followed by TDM1, second line, then other regimen capecitabine plus lablatinib, trastuzumab, navalbin, vinorelbine, trastuzumab plus lablatinib, or trastuzumab or with other agent. Or are positive low burden disease with minimal symptoms, we can add hormonal treatment such as letrozole plus lablatinib, aromatase inhibitor, or tamoxifen plus trastuzumab if disease progression follows the other pathway. There's another summary from metastatic HER2 positive regarding first, second, and third lines. Selected ongoing trial from metastatic HER2 positive breast cancer is still ongoing. Conclusions: incorporation of trastuzumab, pertuzumab, and TDM1 has greatly improved overall survival in metastatic HER2 positive disease. HER2 targeted tyrosine kinase inhibitor appears to be reasonable therapy in HER2 positive metastatic breast cancer in the third line setting and beyond. Tucatinib data are particularly strong. Trastuzumab deruxtecan is a major new pathway approach for HER2 metastatic breast cancer in third line setting, line to move to aerial setting. Second line trastuzumab deruxtecan versus TDM1 also being logged at HER2 low disease, breast density, breast 04. Margetuximab is of unclean benefit till now, perhaps in CD16AF early criers. Thank you.
Thank you, Professor Fatma, for the very illustrative presentation on HER2, anti-HER2 in metastatic breast cancer. And now we have to move. Unfortunately, we don't have time for questions. So we'll move to the next speaker, Professor Dr. Abdelhamid Hussein Izzat, Professor of Clinical Oncology, NCI, Aswan University. And he's going to talk about a very interesting subject, which is breast cancer and pregnancy. And how do you think? Thank you.
Thank you, Mr. Chairman, and my colleagues and audience. Good afternoon. This topic is a little bit general topic, but specific in its item. I talk in specific situation in breast cancer with pregnancy. This talk is there are many controversies. No consensus specific about this topic. My objective is to describe and evaluate the workup of patients with pregnancy-associated breast cancer. Second, identify the therapeutic modalities that are contraindicated and to select the appropriate options for local, regional, and systemic therapy. First, we talk about what is the definition. Pregnancy-associated breast cancer is defined as breast cancer that is either diagnosed during pregnancy or within the first postpartum year. But this definition is challenged due to they think to divide it into two parts: pregnancy cancer, breast cancer during pregnancy, and postpartum. And postpartum breast cancer, which they asked to be about 5 to 10 years post 5 to 10 years postpartum. Thank you. So regarding the workup, the ultrasound is the first modality used for evaluation of palpable breast mass. The mammography is not contraindicated, but it is not the first option. Concerning the breast MRI, It is questionable even because of the gadolinium or the contrast with questionable teratogenic effect. The core needle biopsy is highly recommended, as well as the excisional biopsy for tissue diagnosis and as well for receptors. The fine needle aspiration cytology, I found it's not highly recommended due to the physiological changes that occur in breast during pregnancy. It mimic atypia. So it is not a confirmatory diagnostic for breast cancer in pregnancy. To summarize the diagnosis with a patient presented with breast mass, we have to do a breast ultrasound. If it is benign criteria, it's okay during pregnancy. If it is suspicious, here came the role of mammography to determine if there is multicentricity or not, and then the core needle biopsy. Regarding the metastatic workup, we have to exclude the lung, liver, and bone mets by chest radiograph or with abdominal shielding for the chest metastasis, and liver ultrasound, and then the non-contrast MRI of suspected bone. If the patient complained of tenderness, of a complaint of pain, or there is tenderness, or there is unexplained elevated alkaline phosphatase, we prefer to do a non-contrast MRI. So in the treatment of breast cancer with pregnancy, we have to strict to some general rules. Number one, any type of therapy should follow the same guidelines for non-pregnant women as possibly, as close as possibly. Number two, the treatment is individualized according to two things: gestational age and the fetal safety. And of course, we have three main lines included in the MDT, besides an obstetrician and perinatologist. The main line of treatment is either surgery, radiotherapy, or chemotherapy. Regarding surgery, it can be performed at any stage of pregnancy, and mastectomy is the surgery of choice for operable disease. Breast conserved surgery is an option if radiotherapy can be given within later, some literature say 12 weeks, I think up to 6 months also. Axillary staging in generally performed with axillary lymph node dissection rather than the sentinel node biopsy. Some say that the sentinel node biopsy can be done by scintigraphy only, but the blue dye, whatever lymphazurin or methylene blue, it is contraindicated maybe due to anaphylaxis, contraindicated during pregnancy. But some literature says that we can use the scintigraphy, but the problem also is there is no result concerning the accuracy, specificity, and sensitivity of sentinel lymph node in pregnancy. Concerning the radiation therapy, radiotherapy is generally contraindicated during pregnancy. It is advisable to be given after delivery. Thus, breast conservative surgery is an option for pregnant women in the late second or third trimester. I found a consensus, an European consensus in 2010. They said that if I made an MDT concerning the mother and the relatives, they can give radiotherapy during the second and third trimester. But most literature said that is due to scattered from radiotherapy to the mother, it is not recommended. Concerning the chemotherapy, it is contraindicated in the first trimester, is safer during the second and third trimester. For example, here of chemotherapy regimen, for example, methotrexate is contraindicated. So if you use a regimen containing CMF, we have to change the methotrexate with adriamycin. It should be discontinued 3 weeks prior to labor, And this is because to give time for myelosuppression occurring after chemotherapy for both the mother and the fetus. Also, taxanes and trastuzumabs are recommended only during the postpartum period. For example, here the trastuzumabs had in literature there is an documented oliguria, anhydramnios, and for the fetus with risk of premature labor. Concerning the hormonal treatment, tamoxifen is contraindicated during pregnancy and should be delayed if indicated until post-delivery. And aromatase has no role here because mainly used in not used in premenopausal females. We have to take into consideration the fetal surveillance, ultrasound for anatomical evaluation and growth restriction, growth scan every 4 weeks, antepartum fetal testing at 32 weeks or sooner. Delivery is better to be at term. Reported in literature that there is a placental metastasis, so it is better to be sent for pathology. In the peripartum period, we have an elective abortion may be considered for locally advanced patients presenting during the first trimester. The vaginal delivery is recommended rather than cesarean section unless prescribed by the obstetrician. And here to avoid the infection that occurs from incision, lactation from the treated breast is not contraindicated, and the recommendation at least about 2 years from complete remission to another pregnancy. We have here 8 take-home messages. Number 1, we talk about the definition pregnancy-associated breast cancer and pregnancy with breast cancer and postpartum breast cancer. The last one is the most serious, and they think that they have the worst prognosis. Ultrasound is the modality of choice. Surgery can be performed during any trimester of pregnancy with modified radical mastectomy, the first choice for operable disease, while conservative breast surgery is still an option if radiotherapy is not delayed beyond the 12 weeks. Axillary lymph node dissection is generally performed for axillary staging. Chemotherapy is contraindicated in the first trimester. The following are contraindicated during pregnancy: methotrexate, taxanes, trastuzumab, tamoxifen, aromatase inhibitors, and relative contraindication sentinel lymph nodes. The pregnancy-associated breast cancer carries a higher risk of death because of more advanced disease, larger tumor, increased percentage of hormone receptor negative, and difficult diagnosis, and less aggressive therapy. And finally, less than 10% of become pregnant after treatment, with few data about the risk of breast cancer relapse. Here have an algorithm to summarize a biopsy-proven breast cancer, non-metastatic, of course. If it is in the first trimester, you have to discuss with this patient termination of pregnancy, which does not affect the overall survival or disease-free survival, but it can affect the further management. Either we will proceed with modified radical mastectomy, or she can be out of this algorithm and managed as a non-pregnant female. So if it's the first trimester and she asked for continuation of pregnancy, modified radical mastectomy is offered. Then in the second trimester, we can begin chemotherapy and postpartum adjuvant radiotherapy and adjuvant hormonal therapy if indicated. If it is in the second trimester, still, if breast conservation is candidate, if no, we'll proceed with mastectomy and other chart. If yes, candidate for breast conservation in the second trimester, in the early type, we'll do neoadjuvant chemotherapy first, then for conservative breast surgery with axillary lymph node dissection, and then in the third trimester, we begin adjuvant chemotherapy. If in late second trimester, then we'll proceed with surgery, conservative breast surgery, axillary dissection, then for adjuvant chemotherapy in the third trimester. If the patient present in the third trimester, we offer either modified radical mastectomy or conservative breast surgery with axillary dissection, and then for chemotherapy. And of course, of postpartum chemotherapy, radiotherapy, and hormonal if indicated. Okay. Thank you.
Thank you, Dr. Abdulhamid Azzat, for this clear, concise presentation. Many thanks. And now we will move to last talk, Professor Dr. Muhammad Abdulrahman.
Dr. Muhammad will talk about the adjuvant treatment for HER2 positive and HER2 negative breast cancer.
First, I'd like to thank Dr. Arim for her kind invitation. Thank you, Chairman, and all attendees. Talk about adjuvant treatment for hormone receptor positive HER2 negative breast cancer. I'm Muhammad Abdulrahman, Professor of Clinical Oncology, Qasr Al Aini, consultant at Aswan Cancer Center. Breast cancer is the most common malignancy, and most of patients are hormone receptor positive at presentation. Since many decades, it is well known that breast cancer is a hormone sensitive tumor with estrogen as the main growth factor, and estrogen can easily be blocked by tamoxifen by competitive inhibition in both pre and postmenopausal patients, and it can be blocked in postmenopausal only by aromatase inhibitors. LHRH analog are effective only in premenopausal patients. The term adjuvant means a systemic treatment that given after definitive local treatment to improve the disease-free survival and maybe overall survival. Of course, this is not be free, it would be on the expense of toxicity. For chemotherapy, we should weight the toxicity against the benefit. But in endocrine treatment, we usually prefer endocrine treatment for the high safety, and since Sangal in 2005, no indication for adjuvant hormonal treatment in hormone receptor positive patients. It is given in all hormone receptor positive patients. So our adjuvant treatment in hormone receptor positive HER2 negative may be chemotherapy, endocrine treatment, or other agents like CDK4/6 inhibitors or PARP inhibitors. Our lecture will concentrate on endocrine and other therapies. Chemotherapy needs a specific lecture, when to give, when not to give, when to use genetics in early tumor stage. So we'll start with endocrine treatments, and endocrine treatment will be classified into pre and postmenopausal. In premenopausal, I'd like to ask the role of ovarian suppression, the proper time duration, and for postmenopausal, I'd like to review the data for aromatase inhibitor and what is the role of extended treatment in postmenopausal patients. For premenopausal patients more than 2 decades ago, we have the Oxford data which indicated tamoxifen as it reduced recurrence by 1/3 and reduced contralateral breast cancer by half, improving survival more in older patients, but all subgroups gained benefit from tamoxifen apart from ER negative patients. So tamoxifen can be given to any ER positive patients, but never to be given for hormone receptor negative. For premenopausal, these are the available options: TAM suppression, addition of suppression to TAM or to aromatase inhibitor, which we'll discuss the soft and text, Atlas and Atlas. For the soft and text, these are the studies evaluated the role of suppression or ablation as adjuvant treatment. For the text trial, unfortunately, we don't have a tamoxifen only arm. Tamoxifen at that time was the only golden standard adjuvant treatment. While in the soft trial, we have tamoxifen arm compared to ovarian function suppression added to tamoxifen or added to aromatase inhibitor. In the soft trial, it was a negative trial. No statistical significant difference between TAM versus TAM ovarian suppression. But in patients giving chemotherapy, we have a privilege for addition of ovarian suppression to TAM and to exemestane over TAM alone. And if you will add ovarian suppression, it is better to be given with exemestane rather than TAM. So we have a combined or pooled analysis for the two trials. Unfortunately, the combined analysis did not include the tamoxifen arm alone. But if you revise the data, we'll find that addition of ovarian suppression better to be added to exemestane rather than to be added to TAM for the improvement of the 5-year disease-free survival. Coming to the second question, which is the proper duration of tamoxifen, 5 years or 10 years, we have the ATOM and the ATLAS studies, which showed improvement in the breast cancer mortality and overall mortality with continuation of tamoxifen for 10 years rather than 5 years. And the benefit came mainly after 10 years, which indicates a carry-up phenomenon. For postmenopausal patients, since the year 2004, we have the results of ATTACK trial. The first trial evaluated adjuvant aromatase inhibitors in postmenopausal patients and showed positive results. Then we have 3 agents, anastrozole, letrozole, and exemestane in 3 ways: upfront, switch, or extended adjuvant. So we have 3 times 3, and we have not 9 trials, we have 11 trials till the year of 2011. This is the landscape of these trials. We have some trials like Big 198 that evaluated more than one method of use, and only one study compared 2 agents, the MA27. The TEAL trial started as upfront, then for ethical consideration changed into switch. More than 47,000 patients evaluated. These are the extended adjuvant trials: MA17, Lusterium for the anastrozole, the NSCP for exemestane. And what is beyond extended adjuvants, we have many recently released trials from the year 2018 till now for letrozole, anastrozole, the ideal sol, and the B42 trial evaluated extended adjuvant with letrozole, while the data and areas evaluated extended adjuvant with anastrozole, and we have Oxford analysis for any of the aromatase inhibitors. We have diversity of data, but all in all indicates extended adjuvant with an aromatase inhibitor for 2 to 5 years according to the risk and according to the tolerability, especially bone toxicity. Of course, the use of aromatase inhibitor was not for free, it was on the expense of toxicity. They have different toxicity profile. TAM is better regarding cardiac complication and osteoporosis, while aromatase inhibitor is better regarding endometrial carcinoma and thromboembolism. To reduce this bone effect of aromatase inhibitors, many trials have been initiated. We have at least 2 meta-analyses and at least 7 trials: the ZFAST, the ZOFAST, the EZOFAST, the Austrian trial 12, evaluated the use of zoledronic acid to reduce the effects on bone mineral density and to reduce the risk of fracture. And all these trials and meta-analyses were positive. Then denosumab, monoclonal antibody against the rank ligand, have been evaluated in 2 major trials. It reduces the risk of fracture by 50% in the Austrian trial, and it was Austrian 18. It was the only trial dedicated to the risk of fracture rather than bone mineral density as a primary endpoint. But unfortunately, the DCARE trial tried to prove its role to decrease breast cancer recurrence was negative. This is the endocrine treatment. Coming to the recent released data about CDK4/6 inhibitors and the PARP inhibitor, we have the abemaciclib in the Monarch study and the olaparib in the Olympia study. Starting with Monarch, this is the mechanism of action of CDK4/6 inhibitor. CDK acts through inhibition of the retinoblastoma gene, which is a non-tumor suppressor gene, stop the cell cycle progression. So through inhibition of the stoppage of cell cycle progression, cyclin D has carcinogenic effect. And if you block cyclin through cyclin inhibitor, cyclin D4/6D inhibitors, you will block many pathways: ER/BR pathway, PI3 kinase, mTOR, and MAPK. The Monarch study is a phase 3 randomized trial with 2 cohorts of patients, high-risk patients. The first cohort is high risk due to N2 disease, 4 lymph nodes affected or more, or 1 to 3 lymph nodes with high tumor grade or high tumor size. The second cohort included patients with N1 disease and being high risk due to the high Ki with no large tumor size with no high grade. Patients were randomized to placebo, added to endocrine therapy, or abemaciclib added to endocrine therapy for 2 years, and followed up for the invasive disease-free survival, which is the primary endpoint. Secondary endpoint is the effect of Ki. For the primary endpoint, the study was positive and the effect extended beyond 2 years. For the secondary endpoint, the rule of KI, as you see, the dotted lines are much better than the continuous line because KI is a good prognostic factor in this situation. But its role as predictive value for the response to abemaciclib or benefit from abemaciclib, it was negative. Both groups with high KI or low KI at a cut point of 20% gained benefit from addition of abemaciclib as adjuvant treatment to endocrinal therapy in these high-risk patients. For subgroup analysis, most of subgroups gained the benefit apart from non-Asian, non-white patients, but this small number of patients. Regarding toxicity, toxicity was higher in the abemaciclib arm, apart from arthralgia and hot flashes were higher in the endocrinal therapy arm. Coming to the second agent, PARP inhibitor, olaparib in the Olympia study. This is the biological background of the effect of PARP inhibitor. PARP is a polyadenosine ribose polymerase pathway. It is a pathway to correct DNA damage. Homologous recombination is another pathway coded by the BRCA1 and 2 genes. If you don't have a functioning BRCA gene, so PARP inhibitor will not fix the error, will not fix the single strand break, becoming double strand break with no repair, so cell death will occur. In the Olympia study, which evaluated the role of adjuvant olaparib in germline mutant BRCA1 or 2, group of patients, we have triple negative and we have hormone receptor positive HER2 negative. So if you have a high risk patients with hormone receptor positive HER2 negative, please do germline BRCA mutation. Whenever possible, you can give olaparib as the study is positive, not only in triple negative patients. Olaparib was given versus placebo for 1 year, and patients were followed up for the primary endpoint, which is the invasive disease-free survival, and there was an improvement by more than 40% in the invasive disease-free survival, in the distant metastasis-free survival, and by more than 30% regarding overall survival as a secondary endpoint. Of course, this is not again for free toxicity with slightly higher in the olaparib arm, mainly due to grade 3 and 4 higher toxicity, not due to specific toxicity like second malignancy as suspected, like leukomogenic effect or pneumonitis. So, coming in conclusion, the adjuvant treatment of hormone receptor positive HER2 negative disease involves, apart from possible adjuvant chemotherapy, adjuvant endocrinal treatment as mandatory treatment in all cases with hormone receptor positive HER2 negative disease. In pre and perimenopausal patients, options include TAM alone for 5 years, extended treatment with 5 years of TAM, beyond the 5 years, I mean 10 years of TAM, or if you have an intermediate or high risk, you can shift to aromatase inhibitor if the patient became postmenopausal at the end of the first 5 years of TAM. Ovarian function suppression is mandatory whenever TAM is contraindicated. And you can add aromatase inhibitor better than TAM to ovarian function suppression if the patient is intermediate or high risk. TAM plus or minus ovarian function suppression should be considered in young patients, especially less than 40 or 35 years old. This is according to the ASCO recommendation. In postmenopausal patients, options include aromatase inhibitor as upfront, as extended adjuvant, as switch, with preference of starting with aromatase inhibitor in high-risk patient, especially if they have relevant cardiovascular disease, and it is better to start with TAM and switch to aromatase inhibitor in patients with osteoporosis to build up bone mineral density. Upfront aromatase inhibitors are the preferred regimens in high-risk patients and in patients with thromboembolic possibility as TAM is contraindicated. Extended therapy with 2 to 5 years of TAM or an aromatase inhibitor in high-risk patients, N2-3 disease, depend on the risk and depend on also the tolerance to aromatase inhibitor. Still, TAM alone is a valid option in low risk or say very low risk patients postmenopausal. The recent updates about 1 year ago is to add 1 year of olaparib, and it should be considered to do the germline BRCA testing 1 and 2 in any patients with hormone receptor positive HER2 negative patients, high risk. And 2 years of CDK4/6 inhibitor abemaciclib has proven to improve outcome in node positive patients, and the benefit is consistent. Either KI is low or high, it is not predictive, and it is prognostic in this situation. Thank you.
Thank you, Professor Muhammad Abdurrahman, Professor of Clinical Oncology, Cairo University, for the very illustrative and concise presentation. Unfortunately, again, we don't have real time for answers, so we have many questions, but the time is really running out. Thank you very much. So now it's with all my pleasure to present the last speaker in this session, who is a dear friend, consultant Radu Abdelazim, consultant of psychiatry, Cairo University. And she's going to give us a short preview on the prevalence of psychiatric symptoms in a sample of 200 females suffering from breast cancer. Thank you very much.
Thank you, Professor Tamer. It's my great honor that you're here chairing the session with other distinguished professors and the presence of our colleague from abroad, Dr. Elizabeth, and of course, Professor Reem Ahmed. Well, today I will be speaking about quite an interesting subject because there is scarcity of screening research in medicine at large. Everybody understand English here? في حد ما بيفهمش English ولا كلنا بنتكلم English؟ ممكن نتكلم عربي وإنجليزي. So what we did is we examined 1,200 females suffering from breast cancer. This is quite a number, viewing that it's only me in the department. Only one person is running the psychiatry and creative arts therapy department. So we had to find a solution. And the solution is to open training and to recruit people who will be benefiting from learning, but giving us their personnel in order to be able to do the research. We always have to acknowledge people who supported us, who taught us. And this is my idol, Saeed Abdelazim, my father, my mentor, and the person that I lost recently. 1,200 patients and counting, which means this is an ongoing research. It's not finished. We are still doing it as we speak. So the psychologists at Harmel Institute are working right now to still keeping the data ongoing. It's an ambitious project. Colleagues, namely Professor Hel Aziz and Professor Reem Ahmed, were the supporters for us to complete this job. There were lack of resources, lack of personnel. We had to create the team and implement to gather the sample, working around the clock, even on holidays, to accomplish the work. And unfortunately, some of our beloved patients were lost as sequel of illness while we were gathering the data. This is Professor Hel Aziz, and this is Professor Reem Ahmed. I'll hit the data directly, so we're not getting into a long prelude. We needed to know some demographics before we started checking for psychiatric disease. What is psychiatric disease? Depression, anxiety, sleep disorders, sexual disorders, appetite disorders. They are all very important, and they all do affect the quality of life of every patient, and not only the patient, the entire family is affected. So when we looked at the marital status, you could see almost 60%. So more than half of the patient had no partners, whether the partner left when they became sick, whether the person has another wife, and we all know in our society there is polygamy, and whether she's a widow. Only 40% had partners. The educational level, the majority of the sample, 30%, were illiterate. Some of them had some education, till the preparatory level so they can read and write. And this is so important because as we implement the questions, they're not able to fill their own papers. They need the psychologist to assist them and to explain. And few of them were having high education, and actually quarter of the sample and the other quarter had diplomas, which is a moderate level of education. In regards to the medical condition, we're all here oncology oriented or oncologist. So we know that it's so important to know what kind of disease are we talking about. The majority of the cases had already lymph nodes, so the spread was in process, and they need more than a line. So most of them were on chemotherapy, and of course we know the sequels of chemotherapy. The metastases were only 8% of the sample, and combined tumors mean they had breast cancer plus. So breast cancer and maybe another form, ovarian cancer or brain cancer, they had other tumors involved. Here we go. So how many of them were severely depressed? Almost 50%. Moderately depressed, 40%. And only 15% usually that was correlated to the degree of the illness. So those who had lesser illness or better socioeconomic, because we are still looking further at the data. I'm just moving forward with what we discovered. Anxiety. Severe anxiety in almost 50% again of the cases. Severe anxiety, that means she's frightened, fearful, she's not able to concentrate, she has issues dealing with everyday life. Only 12% did not report anxiety, and moderate anxiety in 30%. 75% of the sample suffered from sleeping disorder, whether early insomnia, middle insomnia, or late insomnia. What does it mean? It means she can spend hours in bed and she's not able to sleep, or she wakes up in the middle of the night, or no matter how much she sleeps, she never rests. Appetite. The poor disturbance, which means, mashallah, in Egypt, the appetite is not the first thing to be affected. Even with people having disturbed mood, their appetite was not that disturbed. Poor disturbed, that means it's not that remarkably disturbed. And the loss of appetite was only in 11%, despite of the chemotherapy, radiotherapy, and whatever lines that they were undergoing. Energy level and strength is so important because we all know here in Egypt that the female is so important, is the anchor of the house. She's the one who notices the kids, who takes care of everything, actually. She's the minister, as we call it. So if she has no level of energy, then most probably the relationship is disturbed. We found that in more than 60%. Extreme fatigability. Yes, it is not a surprise, the findings, I'm sure, but then when we put it in numbers, when we screen 1,200 cases and we know the record, I think we need to address this, whether in management or in medication. We definitely need to look at that because this is the load that they go home with. Nervousness. And nervousness leads to disturbance of the partner relationship with her kids, at work. Many of them left the work or had real trouble because they cannot control their temper. So moderate rise, that means there is still an increase in the baseline, which amounts to almost 78% of the cases had increased nervousness. So what happened to their marital relationship? 10 of them, 10% of the sample had to go into divorce or separation. 53% turbulent after illness. So the partners could not really hold through. And this is so important because that entails that we do need to address partners in treatment. There must be partners session or of how to handle their anger, sadness, how to deal with the patients. We cannot just overlook it and focus on the patient. Sexual relationship. So a lot of people think, well, you know what, sex is not important. What's important is that this woman has to go through. Well, you know what? She's not happy. She doesn't feel like I'm a female anymore. She doesn't feel beautiful. She doesn't feel wanted, etc. When we looked at the reasons, well, some of it were because she's in pain, or she has misconcepts that if the husband touches her organs, then it will spread the disease. And as you look at the percentages, ongoing means the relationship was not affected between both partners. He was able to contain and she was able to go on with the relationship. 25%, they entirely stopped having sex because he's afraid, he's worried. And so she's in pain, fatigue, dryness is a major issue because of the treatments also, because dryness means intercourse became painful. She cannot do it anymore. So all this needs to be put in consideration. And the main bulk was there was no more desire. So this is already a diagnosable psychiatric disorder. It's called hyposexual desire disorder in female, and it mandates treatment. Yes, I am talking today about the screening and what we found, but I thought to leave you with glimpses of hope, intervention, and what we do with all those symptoms. This is the room that we were granted at Harmel Hospital. You could see the tools that we are using. You could see how the patients are being prepared in terms of costume for the intervention. This is dance movement therapy, and it's particularly tailored in order to actually work on the pectoral muscle, on the flexibility, on their backs, on their way of feeling agency of the body. Agency means I can do, I am present, I am no more crippled, I am not handicapped with the illness. This is another exercise, and you could see we covered, because that happened at an earlier time, COVID were still on, and I'm able to use that based on the consent of all patients who actually participated in this intervention, and also hiding their identity. Here, this is another more, I don't want to say riskful, but this patient actually in the intervention, she had drainage. So immediately post-operative, and the drainage is right next to her, and she's able to actually engage in those kinds of exercises. This is another intervention that is modified high intensity interval to work on their energy level, engagement, and agency. And this is usually the type of circle that we do, where we have the feedback. Most of you know that after the operation, many of the patients cannot comb their hair. So to be able to assist them to do this movement is actually quite something for them, because they feel less handicapped. And thank you very, very much. I'm almost done with my time. So I appreciate your presence at this time of the conference after the end of everything. And I appreciate your attentive listening. Thank you.
Thank you, Professor Radwa, for a very interesting and a very illustrative presentation. And I think that cancer patient would rather need the psychological support more than the medical part of the oncologist. Thank you very much. So here we will just going to end this session, Professor, and thank you very much for all the attendees, the very elite attendees, and thanks for the chairperson sharing with me this session. Thank you very much.